Welcome to ADAPT's training. My name is Omar Tausif and I'll be your presenter for this module on mental health first aid. A few things about me. I have been working in the mental health field for the past 13 years. I'm a qualified mental health counselor. In today's presentation, I'll try to share some of my own experiences and examples, some tips, tricks, things I've learned along the way. So let's move on with what mental health first aid is. So just like you may have received a training on physical first aid from an organization like St. John's or Red Cross, which would have equipped you to help someone who is injured or if someone has been in an accident, the idea is for you to have those basic life-saving skills, which you can apply till the paramedics apply or till the individual could be transported to a hospital. But the idea is that that time is critical when you can sort of assist a person and some of the actions that you might take during that crisis could be life-saving. So similarly, mental health first aid is also something that is given until a person receives professional help or if the crisis resolves. So the idea is that we are trying to assist someone who is facing a mental health problem that could be pre-existing, or if there's a worsening of that pre-existing problem, or a person is facing a situational crisis which has developed as a result of some factors, for us to have those skills and to have some strategies, what we can do as first aiders to offer that basic support, to be able to identify some of those symptoms, and if there's any immediacy, do we need to escalate it to the emergency staff, and for you to also feel comfortable in your basic skills to respond to someone who might be in that distress. So as a mental health first aider, who can you help? Well, look, obviously there are very frequently occurring conditions, depression and anxiety, which you may view a lot, and whether that's a friend or a family member, a spouse, sibling, colleague, that obviously is quite a handy skill to have if you were in contact with someone who's experiencing depression, anxiety. Some of the skills that you're gathering here could also help someone who is undergoing a psychosis or substance use problems, eating disorders, distress caused by gambling problems, if they're experiencing suicidal thoughts and behaviors or self-harm, panic attacks, and then there's obviously other things such as someone who's been exposed to any traumatizing events, or if they've been vicariously exposed to traumatizing events, if they themselves are exhibiting aggressive behaviors, or they've witnessed someone who has been exhibiting violent or aggressive behaviors. These could be some of the categories that we can help a person who could really benefit from your set of skills that you're gaining from mental health first aid. So let's establish what mental health first aid is and what it's not, just so that you do know the scope of your helping. So like we said, that mental health first aid training equips you to have the knowledge and those skills to support a person who's either developing a mental health problem or they're undergoing a crisis where you may be the person who is in their vicinity, or you are the person that they've disclosed something to, or you are someone who's witnessed some of those difficult behaviors, where you may be that individual who can offer that help while professional help is sought. So one of the things that a mental health first aid training is helping you is to become very good at spotting some of those signs of mental health issues. So let's not confuse that with diagnosing that's something that's a highly acquired skill that a professional psychologist or a psychiatrist or a mental health professional might have, where they're able to diagnose someone on the basis of their own psychological and psychiatric knowledge and experience. However, for you as a mental health first aider, you may be aware of a person's mood, or if there are changes to their behavior, if their energy has changed, some of their habits have changed, if you've noticed something changing in their personality. So these are things that you may be privy to now that you're living with someone, or you're friends with someone, or you're working with someone. So one of the things that we're trying to really hone into is to be very proactive in spotting some of these signs of mental health issues, and understanding these that might be emerging in a person. We're also trying to establish some of those skills, um, how we may intervene, and what would be a sensitive way of approaching a person who is experiencing issues. Things like how to initiate this, what should we say to them, how to say that, things like our tone. What if they don't wish to speak to you? Then what should we do? Should we withdraw from there? Should we try to reestablish that help? So those are things that we want to cover in the scope of our training today. Further, we also want to be a source of support, because just like in lots of medical conditions, we know that an early intervention might be very important for better outcomes. Similarly, in emotional health issues, we know that similarly, and that's what research seems to also suggest, which is the earlier we can catch some of these changes happening in the persons, like I said, energy, habits, personality, mood, behaviors, emotions, and if we can either help an individual resolve them with a mental health first aider, or if that is something that needs to be passed on to a mental health professional, the earlier we can get that good accurate support for a person, the better those outcomes for their mental health. So we're equally sort of interested in developing that very critical mindset, that what could be some of those interventions so that we're providing and when. Likewise, as a mental health first aider, you are learning how to handle difficult situations that might be emotionally very intense, or that might be emotionally quite difficult for you to witness, and learning what sort of questions could you be asking, how could you be showing support, what resources are available for you, things like how should I be listening to a person, or what questions can I ask or not ask. Equally, I think what's also very important is to recognize what mental health first aid is not, and where our skill set exhausts itself, where we should not sort of try to help a person. So where we're reaching out to someone who you suspect might have a mental health problem that you're not qualified to help, then what should we avoid there? And who should we be contacting instead? These are important skills that you're acquiring that establish that scope of your mental health first aid skills, when to apply them and when not to apply them. I'd like to take a couple of minutes to do an exercise. So if you're attending this training on your own, you can do this on your own. If you're with a group of people, you guys can do this with each other as a group. So what I'd like you to do is just think of a person, a friend, colleague, family member, sibling, whoever you can, who may be undergoing a mental health crisis. So just take a moment or two thinking of someone who may catch your attention. Okay, so if you now have a person in your mind, think about what you may have noticed about their symptoms. And how do you know that these symptoms exist? Have they shared it themselves? Has someone else shared this with you? Is this in contrast to how you've known them in the past, that something has changed? Can you see how this impacts their daily functioning at school, at work, at home? Are you the only person who's noticed it, or are there other people who might have also noticed some of these changes? How long has this been going on for? Has it been gradual, or are some of these changes very sudden? So hold on to some of these things you may have noticed, and If you're on your own, maybe just sit with some of these things that you've gathered and see if something emerges for you, such as if there's something that you're wondering what you can do, what sort of things might be helpful towards them. If you're in a group, if you have any experiences where there might be someone around you, a loved one, a friend who is presently experiencing a problem, if you feel comfortable in sharing that. What sort of things have you noticed? How did that catch your attention? And obviously, please do remove all identifiers to make sure that you're protecting that person's identity, just so that we're trying to only use this for educational purposes and not to violate anyone's privacy. Before we dive in some of those skills and interventions that you may utilize as a mental health first aider, let's understand how this field exists, what some of those common disorders are in Australia that you're likely to witness. So the recent statistics show that 2 in 5, that's almost 44% of Australians between ages 16 to 85 are estimated to have experienced a mental disorder. That's around 8.6 million Australians. Now just imagine that staggering number. And in the previous 12 months, that may be 1 in 5 people. So that's almost 4.2 million people. So those numbers might indicate that how common mental health problems might be, and the likelihood of your meeting someone. So just like I said, that 20% of individuals in the last 12 months have had some sort of a mental health crisis, and that necessitates our having that skill set, what we can do if we are in contact with someone who is undergoing a present crisis. Likewise, with anxiety disorders, that's around 17% of adults. That's around 3.3 million people. When it comes to affective disorders such as depressive disorders, that's around 8% of the adults. Likewise, with substance use, that's 3%. For children and adolescents, so between 4 to 17 years, who have experienced a mental illness in the past 12 months, that might be almost 1 in 7 or 14% of these individuals. Likewise, the number of people who are estimated to have a severe mental illness in Australia is around 800,000 people, of which 500,000 have some sort of an episodic mental illness and 300,000 have a persistent mental illness. Likewise, if we look at these numbers cumulatively, what we'd see is that mental health and substance use disorders are the second largest contributor. That's around 24% of the non-fatal burden of disease in Australia. So these numbers might indicate the gravity and the pervasiveness of emotional health crises, not only in Australia but globally, which necessitates us to have those mental health first aid skills, because there's a very high likelihood that someone around us in our neighborhood, a friend, a spouse, a child, a colleague, someone might undergo a mental health crisis, an emotional health crisis, where our skills might be very life-saving for them till we can get them further help. So how can we differentiate a mental health disorder from a general mental health? So whereas mental health is a part of our everyday life, we have our ups and downs, we have good and bad days. It's a very normal thing for us if we've received bad news at work, or a loved one is going through a health crisis, or we are transitioning in our employment, or the impact of the cost of living crisis, or the ecological distress, or the environmental distress, or the stress at work, or having a difficult boss, or relational distress, whereas those are parts of our normal everyday functioning. When do we know that something is not just about mental health, but it is becoming disorderly, or it might be a sign of something that could be a mental health disorder? Let's have a chat about this. One guidance are these 4 Ds. That's distress, deviance, dysfunction, and danger. Let's have a chat about this. So people who are undergoing a mental health disorder a lot of times are exhibiting signs of distress. They may be deeply upset or troubled by some of their symptoms. They might be causing them a lot of difficult feelings that are making it difficult for them to be around people, their loved ones. People around them might consider some of these as being very abnormal, or they may see their condition as being very upsetting for them to view. So distress is something that may indicate that a person is presently finding it very difficult to cope with whatever their situation might be. But I want to be very mindful of this, that distress is a highly subjective concept. What might be distressful for them might not necessarily be distressful for you. So we're looking at the other person's distress. We're not looking at your interpretation of that. We're not looking at your evaluation of that. We're trying to stay clear of that so that we can focus on what the other person's experience is. So the second factor that might differentiate disorder from mental health is dysfunction or disability. So generally speaking, psychological disorders may cause some dysfunction in a person's functionality in their everyday life, whether that's at school, work, in their home, whatever their functionality might be, what their productivity is in their relationships, how, if they're able to think clearly, how they are communicating, are they able to function at their school or work, are they able to exercise, are they able to eat. So one of the signs of a disorder might be that a person is having a lot of difficulty sort of doing things which under ordinary circumstances they were able to do. So the third factor is that a disorder generally might be a certain deviation from social norms. A lot of times psychological disorders can be statistically rare, but that's not always the case. Earlier when we talked about things like depression, anxiety, they may be fairly common. Some epidemiological research might indicate that depression might occur in anywhere between 20 to 40% of a general population over a lifetime. And then there are some statistically very rare disorders, like a dissociative identity disorder might be a rare disorder. However, one indicator of a disorder might be that it deviates from some sort of norms that are considered quote-unquote normal in a society, such as in a lot of Western countries, talking to oneself, for example, might be considered a sign of a mental illness. This might be a sign of a hallucination, where a person is seeing something outside of them, and if that's not based in reality, psychiatrically, that might be seen as a symptom of a mental health illness. But that deviation might not in other cultures be seen as a deviation, such as in lots of indigenous cultures around the world. Conversing with ancestors, having that very lively relationship with people who've passed, may even be seen as a very healthy form of keeping a connection with one's spiritual life. So although this is seen as one of those indicators that we can use to assess if someone is facing a disorder, but this might not always be true. So whereas here's what we're saying, that whereas this particular guideline that a lot of times psychological disorders are considered to be deviations from norm, a person is acting in a way which is generally not considered to be acceptable, such as we would expect people in our everyday life to sort of have that energy and be able to regulate their mood and eat and sleep. So whereas that's considered to be quote unquote normal, someone who's deviating from that by being extraordinarily sad or not being able to eat or being having some of those difficult symptoms might be considered a deviation from that sense of normalcy, and we might think that they might have a depressive episode. So we'll talk about that further, but that can be used. However, just like I said, that's also something that we want to practice some caution towards, because there might also be lots of cultural differences. There might be lots of other differences across individuals, gender-wise, class-wise, based on their sexuality, other differences across individuals. But that can be one indicator that we could use towards quote-unquote abnormal behaviors. And the fourth such guidance can be if the symptoms that a person is experiencing, if they pose a risk of danger to themselves or to others around them, then this could also be indicative of a psychological disorder. Although this variable may not always exist, however, in a lot of psychological problems, we may see some escalation of danger, such as if a person may be suicidal or homicidal. So we don't want to use this as a rule. It may not always be that a person may endanger themselves or another person. That could be an indicator or a flag that sometimes shows up when someone is experiencing a disorder. So taken together, now do know that these are those very critical reflexive places that for a mental health professional, they are usually sitting with these. A lot of times these are conversations that might be spread over many sessions or many weeks and months. There might be multidisciplinary teams, such as between a psychologist, social worker, and a counselor, who are establishing some of these together to ascertain if there's a disorder in place and what sort of interventions might be in place. However, for you as a mental health first aider at this point, you're just trying to understand that what are some of those things that I could be mindful of, such as if a person is in distress and is their life being affected through those symptoms of those what's causing that distress, and is this something normal, what they're experiencing, and are they endangering themselves or someone around them. These might give us a clearer picture of if something needs further attention from us. All right, let's move on. So let's first take up depression, as it's one of the most common mental health challenges that people might face, not only in Australia but globally. So what are some of those symptoms of depression which might indicate that someone is going through depression and not just experiencing ordinary sadness? How do we differentiate symptoms of sadness from something that's more clinically relevant? So when it comes to depression, we were looking at a persistent sad or irritable mood where a person has a loss of enjoyment or interest in things that they were interested in. We might sort of see how things like their energy is depleted, they're tired, fatigued. They might have a very low sense of self, feelings of worthlessness. Suddenly they might feel that sense of, I'm not good at anything. What's the point? I've lost so much time. They might have lots of thoughts of death or dying. Sometimes there might be suicidal ideation where they actively want to take their life, and at other times it might just be a lot of morbid thoughts what's the point of living, or life is meaningless. Likewise, we may have individuals who are reporting difficulties in concentrating, making decisions, feeling that even small-scale everyday decisions, such as which brand of cereal to buy, might just become difficulty. Likewise, we might see difficulties in sleeping, in eating. Sometimes a person who's experiencing depression, they might be sleeping too much, or at other times they may be sleeping too little. Likewise with food, sometimes they're eating too much or eating too little. So there might be a weight gain or a weight loss. So these are generally signs of depression. Now, in terms of diagnoses, obviously this is something that needs to be taken to a person's GP, and they may run a checklist, and if they feel that this is something that needs to be further escalated to a psychiatrist or a psychologist, based on the immediacy, based on the severity of the symptoms, that's obviously a very different assessment. But for you, if you're experiencing someone around you who has at least a few of these symptoms, and that's not just one day, because lots of times I think that misconception also exists, that let's say that if you've heard bad news at work, you're being asked to leave, and due to that, let's say that you're feeling terrible about yourself, or let's say that there's a huge transition that you're going through, and there's a crisis you're going through, and due to that you temporarily are feeling unhappy, and that's gone on for a day or 2 days, but on the fourth day you sort of are okay. So those are differentiated from a more clinical nature depression, where we're saying that not only are these symptoms occurring together, at least 4 or 5 of them, but they might be occurring for most of the day. So it's not like the daytime is okay and it's only at night that you're experiencing it, but you're experiencing it throughout the day, and you're experiencing it many days at a stretch. So it might not be that you sort of were miserable just only during the weekdays when you were at work, but over the weekends you were just fine, but this is pervasive. It sort of is occurring despite good and bad times. It's occurring despite the time of the day or who you're meeting and what's happening. It's just there. And I'm in the next slide, I'm just going to show you a video of some of the people who are talking about their own depression, and that might give you a fair idea of how some of these things are such common symptoms of depression, and as people talk about their experiences, you'll get a better idea of that. So let's watch that video.
I was 18 going on 19 years of age. I just left home to go down to Canberra to go to university. And I was down there probably for about 6 months. And things weren't right. I wasn't quite sure what was wrong. I just felt sick all the time. I felt really angry. I just struggled to get out of bed. I just didn't feel free.
I was working very long hours. I was quite isolated. I was living about an hour and a half away from my family, and things just became quite overwhelming, and to the point where I wasn't really able to cope.
I was really enjoying going around to these obscure whistle-stop libraries, feeling really good, and until one particular evening when I guess the depression or the anxiety simultaneously snuck up on me, and it was like being hit with a feather. I was speaking in a large library. All of a sudden I lost my history, I lost my way, I lost my voice.
My depression came on through circumstantial things that happened in my life. My dad committed suicide. I broke up in a long-term relationship. I was accused of stealing money, and I was chugging along okay until I did a knee injury. And up until that point, exercise had been, I suppose, my way of coping. And when that was taken away from me, I floundered very badly. I just wasn't able to sleep. I wasn't able to eat. I didn't want to do things that I normally did. I was crying a lot, but still saying there's nothing wrong with me.
I didn't notice until people pointed out to me that I was having socialising problems. I was getting angry. I didn't realise that either. It was just, I just thought it was just life.
After a while, I realised it wasn't normal to wake up in the morning and have these sort of feelings of helplessness and this blue sort of cloud that would envelop me, and then realise that I should start speaking to someone, and only then did I start speaking to family and friends and started to realise that, oh, hang on a minute, this is not normal behaviour, and there are other people out there that are in the same situation.
By the time I sought help, I was hardly able to function effectively. I was scared to go outside, scared to go to work. I didn't have the confidence to to get a job, to study. I couldn't keep my thoughts together enough to read or to write.
And they said, you've got clinical depression and serious anxiety. And they gave me a referral to a city clinic.
Then I was hospitalised, and that and my mum just saying, no, we're not going to, you can't push me away, you can't keep pushing me away. We're going to talk with this, we're going to deal with it. That started my road to recovery. So I then had to admit to myself that yes, I did have depression. And then I started, in conjunction with medication, I also had some counselling as well, and that started me on my road to recovery.
And it wasn't until my depressive symptoms reduced and I was able to engage in therapy that I actually then accepted the diagnosis and acknowledged that that I did have an illness.
They diagnosed me with having depression, and I was in counselling for a long time and on medication, and that's how it all started.
So in this video, you just saw some very challenging conditions that some of these people have faced. So one of them was your friend or a colleague. As a first responder, how could you have helped them while they were experiencing depression? So one of the first things that is very important is how we're offering that emotional support to someone who's experiencing depression. Often just taking that time to be available for that other person and letting them know that we care. Never underestimate the value of that. So sometimes when I work with my clients where for many weeks and months nothing in their life is changing, and it might seem like that they're just coming into those sessions and they're saying, well, look, I'm really struggling here, but nothing is changing. In time, when that depression uplifts, they're really grateful for having that space where they had that safe space where they could speak to someone about some of their challenges, and they're experiencing some very negative feelings or whatever might be their symptoms that are coming up. But the idea is that as a first responder, you can always be offering that emotional support where a person's experience, no matter how painful that is, for them to know that they're not alone, and you are able to understand them, you are able to understand how they're feeling, and you care to be there for them, and you care to want to help them. So it might be important for you to tell them that they're important to you and they're not alone, and that you are there for them. Likewise, you can always, as a first responder, encourage the person to talk to you, for them to know that they have a safe space with you where they can talk. So their difficult thoughts or their feelings or any problems they're experiencing, such as even they're being able to say, well, look, I just can't even get out of my bed, and you're being able to really just sort of empathize how difficult might it be for someone who you know who's productive and who's able to show up to classes or show up to work, and hear this individual is just revealing that difficult information to you, that it's difficult for them to even get out of their bed, or someone who formerly was very engaged in some of their goals and pursuits is now telling you that they're just not feeling if they want to even live any further. So we are sort of giving that safe space to another person. We are encouraging them to find those ways where we can head towards that problem resolution. So we can ask whether something has happened to them, or if there's something that's recently happened that's contributing to this present feeling. Now it's obviously very, very important that while you are offering that mental health first aid, you yourself remain calm. It's important for you to be discreet, for you to keep that confidentiality when someone is disclosing something vulnerable to you about their mental health, about their emotional health, about their struggles, for you to not use that material to gain leverage or to disclose that to someone that they may not want you to. Obviously, the exceptions are if there are any safety issues that are involved. There, we're not promising that we might not disclose that material. We'll come to that in a bit. what to do in those situations. But obviously, let's also recognize that people who are experiencing depression are often very overwhelmed. This is difficult for them to view this part of themselves that's feeling that sense of helplessness and those fears and that lack of confidence. And we want to be really gentle and understanding of someone who's in this state. You should offer them your kindness, your attention, your compassion, your support. Will have a hugely positive impact, even if you may not be able to see that just now, but in time they'd be really grateful for your having been there. It's not about what you're telling them that may get them out of the situation, but it's just about your being there. Sometimes we really underestimate the power that our just gentle, compassionate presence can have for another person who's experiencing depression. So likewise, for you to be approachable, for you to take that time to talk, and equally, if the person does not have the time or the energy, or if they're not feeling up for it, for you to not put that pressure, but letting them know that you're approachable, they can get in touch with you when they're ready to talk and you're available for them. We want to treat a person who's experiencing depression and they wish to, and if they are talking to us, to treat them with respect and dignity, to still respect their autonomy, to not make decisions for them, to not override their sense of self by telling them how to fix this, to respect their privacy, unless if, like I said, we're concerned about the risk of harming themselves or another person. And a core skill that a lot of counselors, people in the mental health field, that they work hard to develop is how we may become good listeners. But that's not just a skill that we share in the mental health field. You as a first responder can develop this. You as an empathic individual, a friend, a family member, a colleague, you can develop that. So let's touch upon this. What can you do to become a good listener? So some things that might be key attitudes, such as not holding a judgment, so that non-judgmental stance, having an acceptance, that genuineness, that empathic care, that attunement, that presence, that being centered and being open with your body, with your non-verbal sort of gestures. You're having that kind, warm eye contact with the person, not being rushed. Really sort of sometimes it's in those small gestures, being that active listener, not interrupting a person, nodding or verbally following, saying, yeah, I see that, or asking those open-ended questions such as, hey, how are you feeling? Or rather than just saying, hey, are you depressed? So opening up that space for another person where they really know that they're welcome. It's like being a good host. It's the difference. If someone's come to your home, if you just sort of crack the door open and say, hey, what do you want? Why are you here? Versus really opening your heart and your mind and your house and your door and your time to that person, saying, hey, do you want to come have a cup of tea? Do you want to talk? So being that really generous, kind host, these are those attitudes that can make us a good listener, that makes a person feel welcome. So things like what makes a person be a good listener could also be how we are verbally following a person. Sometimes even it could be helpful just paraphrasing or restating what a person has said, such as, let's say, if Mike is just telling me that, hey, I just had a tough day at work and my boss just said XYZ, and then I went home, and then I had a fight with my partner, and then I was just mowing the lawn, and that was so difficult for me to just have the difficult conversation with the neighbor. So while I'm following that, I can say something like that. Hey, Mike, it sounds like it's been a series of difficult things that have happened in this day at your work and at home and with your neighbor. And how are you doing with this. So now that gives the person that opportunity to not only know that we heard and we followed them, but also for them, let's say that what we've offered them, if there's bits and pieces of that they disagree with, or they want to further explain that may give that person Mike an opportunity to say, yeah, I mean, now that I'm thinking about that, there was another thing that did happen in the middle, or now that they hear us sort of give that back to them, what we've heard from them, they might say, well, look, although, yeah, I mean, so many bad things happened, but here's another thing that was quite on the contrary. So a part of being a good listener is really just checking our understanding of what we've heard, restating, summarizing. These are some of the skills that counselors very regularly use, and you can also use them as a mental health first aider. Yeah, and another such thing that you can do towards someone who's experiencing depression, have realistic expectations that sometimes we can have that writing reflex that as soon as someone has disclosed something difficult that's happening, we want to tell them that, hey, this is the right or wrong way to do this, and do this or don't do this. Instead, we want to be realistic that depression is an illness that may have a certain prognosis. It may have treatment interventions. There might be a certain time period that a person might continue to experience some of those difficult symptoms. So we want to be realistic, yet we do want to be hopeful. We want to encourage a person by telling them things like, well, look, now with time, with treatment, they may feel better. We want to give them that hope of a more positive future, for them to know that's important. Hold on to that. There's more. Yet we want to be realistic around those things, which is if a person is saying, well, I can't even get out of bed, or I just don't feel like coming to work, then acknowledging this challenge, yet being realistic, which is that this doesn't mean that they're lazy or they're doing something wrong, but by definition, that's one of the symptoms of depression, and that person might lack energy or be lethargic, or have difficulty starting their day, and their energy mobilization might be deeply impacted. Yeah, and also sort of something that's very important is for us to encourage a person to seek help. Not only sort of inculcating that hope of that recovery, but saying that there's good help available. There's multiple sources of help, and including if they're feeling really overwhelmed with that process, that how can they, or they don't know, then as a first aider you can really set them up by even sort of talking about a process that, well, look, the first step of this is going to your GP. They might screen you for depression, so make sure that while you're at the reception, ask for, when you call the reception, ask for a longer consultation, so that the GP may be able to screen you for depression and anxiety. Or let's say that if a person is saying, well, they're really struggling with even making that appointment, checking with them that if they may like you to help with that by you're making that call to the doctor, or if they need someone to go with them to that clinic, to the doctor. So we can always offer what might sort of be those facilitative factors for them to encourage that help, but sort of really helping streamline the process. Of, look, you might go to a GP who might assess you for depression. If they may then further put you on what's called a mental health care plan, through which they can access subsidized care from a psychologist that's covered under Medicare, what that might mean for them, and how can they look for a psychologist, what could some of those resources be, who could be some of those local psychologists, should we look them up on Psychology Today, or should we look that up on Health Direct, or if a GP might think that it's necessary to refer them to further specialist care, such as to a psychiatrist, or if there are very difficult, severe symptoms of depression, which might bringing in some risk or some suicidality, the GP might decide to make to either refer to a psychiatrist or to an inpatient hospitalization. Likewise, there might be options within community healthcare centers. There might be an immediate, as a first responder, we might, while we have that person there, we might ask them, well, look, do Do you want to have a chat with one of the helplines? We have plenty of good ones. There's Beyond Blue support service. There's Lifeline. There's Suicide Callback Service. There's Sane. There's Grief Line. There's Skids Line. There's lots of different lines where some of these are 24-hour lines where a person can talk, and we can check if they may want us to help them making that first contact with professional help. So these are some of the things that as a first responder you can do when someone is experiencing depression. Let's also talk about what not to say to someone who is experiencing depression. So sometimes it's very easy for us to see physical illnesses as very legitimate sort of causes of distress and disability. Let's say if someone has unfortunately had an accident or an injury, and let's say they've broken their leg, and while they're limited in their mobility, we might not sort of blame them for their condition. Or someone has cardiac problems, or if someone has diabetes, we may not sort of look at them in that way that they should be doing more than what they are presently doing. We might be a lot more empathic, but when it comes to mental health conditions, when it comes to emotional health crises, we can generally have that judgment where we might feel that a person should be doing more, and emotional crises are things that a person should be overcoming. And then especially if we add there might be lots of gendered elements to that, what we expect from a man and what we expect from a woman. There might be some elements what we expect from someone who is of a certain age. We might expect that from different categories of individuals whom we may assign certain expectations. So when it comes to depression, we want to be very careful that we're not saying something like, hey, just snap out of that, or you'll get over this, or why are you thinking so negatively? This will be all right. You'll be all right. Think positively. Get your act together. These are things which could be really dismissive. If in some ways we're saying, hey, it's all in your head, and you just need to get busy, or you need to just put in some more effort, or you're struggling to do these things. It's just a temporary thing, and you'll move past it. That could be extremely dismissive, and a person may feel that their experience of depression is being trivialized. They might feel that pressure to put up that smile for other people, because other people continue to say things like, hey, chin up, cheer up, lighten up, what's the big deal, this will pass. You've been through more difficult stuff, and the worse if there's some comparativeness, which is that, hey, other people have it worse, or why are you so overly concerned about your partner leaving you? There are worse things that can happen. Or why are you so concerned that you've lost your job? Look at, sometimes people say very silly things like, look at people who might not even have enough to eat, or that may make a person feel that they're doing something wrong, and they should have done more. So that might be something that may even make their symptoms worse. So we want to be very cautious that we do not want to apply those labels which may make a person feel dismissed or belittled. Even saying something like, hey, you don't seem that bad to me, you just seem fine, when the person might disclose something about feeling depression, and saying, hey, well, you seem just fine. Or on the contrary, saying, you look like you have a depressive disorder, or you look like you're clinically depressed, or you look like any of those difficult labels. Please do remember, as a mental health first aider, you should not be diagnosing. However, just like we were discussing in the previous slide, that your role is to provide that safe space for a person who's experiencing depression to be able to talk about their feelings and their experience of depression. Likewise, we want to be also very careful in our tone, how we're speaking to someone who's experiencing depression. We obviously want to be compassionate, but we do not want to victimize them. Likewise, we do not want to be patronizing in a way that, oh, no, you'll be fine, or sort of sometimes being toxically positive. Oh, I've seen these sort of things, and oh, you'll just be fine. So our tone of voice needs to match where a person is. We also want to not nag the person to do things that they're unwilling to, such as saying, oh, I know my cousin, when he was going through this, he just went to this camp, he just took a vacation, so why don't you do that? Or, hey, just take a couple of weeks off from your work and you'll just be fine. We don't want to force certain outcomes to a person. Instead, we want to collaborate with them. We want to ask them, hey, what might help you? What do you really need? How can I facilitate? What can I do for you? Obviously, an exception to this could be if a person has disclosed something pertaining to carrying out harmful or dangerous acts. In those cases, we'll talk about that a bit later in this presentation, what you could be doing. But in other things, we want to be very cautious that like we said earlier, that their dignity, their autonomy, we do want to afford that to a person. Likewise, never suggest that they use substances, alcohol, or other drugs, and saying, hey, yeah, I mean, you're going through this tough breakup. Why don't you sort of just come over? Let's get drunk. That's going to help you. We want to be very cautious that while someone is going through depressive instances, or if they're having a tough time with depression, then we do not want to encourage substances. They can sometimes even bring out more suicidal feelings, and we'll discuss that in a bit. All right, so moving on from depression, let's talk about self-harm and self-injury, which is another category where, as a mental health first aider, you can help someone. So how might we know that someone is injuring themselves? The usual things that data indicates is that towards self-injury, 41% of people they have been cutting. Then a similar proportion of people might be scratching, hitting your body against a hard surface, punching, hitting, or slapping oneself, biting, burning. These are some of the common means through which people are self-injuring. So here's one important thing that you want to remember as a first aider when it comes to self-injury, that we take all self-injuring behaviors very seriously regarding of their severity or the intent. We do not make light of this, or we do not take this lightly. We want to take this very, very seriously. So although self-injury is more common in young adults and adolescents and children as compared to adults, but obviously there's a wide range of individuals who might be self-harming and self-injuring. So let's understand this, including its relationship with suicide. A lot of times people who are engaging in this self-injuring behaviors may not be suicidal. However, they might be a high risk of a suicide attempt. Sometimes this might be as high as 60% of people who are self-injuring in the next couple of weeks or months might have a suicide attempt. So do not assume that people who are self-harming are suicidal, but sometimes that is true. There's only one way of knowing that, which is just to directly ask the person if they're suicidal, and we'll cover this later. There's a separate section of this training on suicide. That's obviously a very important part of this training. So what sort of supports are available if someone discloses their self-injury to you, or you've noticed self-injury in the person. So obviously mental health care professionals such as a GP or a psychologist, psychiatrist, school counselor, an accredited mental health social worker, these are all individuals who are able to provide that assistance to someone who is engaging in self-injury. Mental health services such as suicide lines, the really good ones such as the suicide callback service and Lifeline, they're particularly focused on someone who is presently experiencing safety or risk issues. They're very good at and they're 24 hours a day. They're free of cost. They're accessible to most people, and we generally as first aiders want to know that these are always available options. Likewise, mental health community groups, these are all able to provide that support and assistance to someone who is presently self-injuring. So how can you really approach this topic with someone who is self-injuring? If you suspect that someone in your friends or family is cutting or is presently punching or hitting themselves or burning themselves, you need to discuss this with them, directly approach them. You obviously want to choose the right time and space, that it's private. Directly express your concerns that you believe that you've noticed some marks on the body, or you've seen that that they regularly go to the bathroom. You've seen bandages in a certain part of the body. So although self-injury is a very private thing and it's a hard thing to talk about, so do not demand that you wish to know if they're not ready to talk. However, we are expressing our concern to a person that, look, I'm really concerned. I've noticed this, or a lot of times I've noticed that you're coming with injuries on your forehead, and I've been really worried about that. If a person is receiving any psychiatric or psychological help and you already know about that, you can always check with them if their treating professional knows about these injuries, and if they don't, you can always encourage the individual to talk about this. So what do we say to someone who is self-harming? Look, now there are various ways to do this, but we can focus on what a person can do to make their life more manageable, and what they can make what they can do to make their life less stressful. Our job is to be supportive, to be non-judgmental, to offer them that safe space where they can talk about this, which is what are some of those factors that are leading them, or which are leading to the self-harming behavior. In a large majority of people who are presently self-injuring, they are doing that to relieve the psychological or emotional pain that they're undergoing, as they can a lot of times not do anything about reducing their emotional pain. Injuring or self-harming might be a very quick release. It releases endorphins, and it can be something that the person feels some power and control over their difficult situations, that at least this is something they can do. So we are, as first aiders, providing that space where we can express concern, we can actively listen, we can ask the person about their self-injury, we can give them that support and reassurance. Likewise, we can reassure them that there are sources of help and support that's available. There's a very important thing that we do not want to promise that we will keep this as a secret, especially if this is a minor, depending on what your relationship to them is. If you are working in an educational setting, or in lots of, you can check your state legislation regarding this. But if you are a mandated reporter, then obviously, if there's any sort of signs of neglect or harm, or if you know that someone's self-injuring, you may need to notify an adult or child protection. However, we never promise the person that we will keep this a secret, especially if that's a minor. Depending on your state legislation, have a chat with your team leader or your support staff about what your responsibilities regarding this is. But even as a first aider, we obviously do not want to gossip about this. But if someone is disclosed about their self-injuring, we don't promise that we'll keep that to ourselves. We can say something like that, which is, look, I'm concerned about your safety, but I cannot promise that I will keep this information to myself. So what do we do if medical attention is necessary? Obviously, if a person has a wound, or they're in pain, or there's a cut where there's a lot of blood oozing that requires medical attention, if something might need stitches, you obviously want to call 000, or you want to check with your own facility if that physical first aid can be provided. If a person has overdosed or they've consumed a poison, you want to call an ambulance, as the risk of death or permanent harm is very high. So we also want to know that when do we escalate this? What is a situation where medical attention is necessary? In contrast to if someone just has superficially just cut themselves, especially in teenagers, sometimes you'd see that they might take a sharp object like a pen or a pencil, scratch themselves, or they might just sort of bite with their own teeth, or they might dig their nails in their skin. They may not necessarily require medical attention. However, we'd still be attending to that as a self-injuring behavior. But for us to also know that when do we escalate that, and where we need to get medical attention from. Let's now talk about panic attacks, which are a fairly common condition that affect millions of people. Like we reviewed earlier, that around 17% of people in our population may be experiencing anxiety symptoms. That accounts for millions of people who potentially are experiencing panic symptoms, which is a sudden onset of extreme discomfort, fear, which can very quickly catch up. And during this time, a person may experience symptoms such as they may have palpitations, they may almost feel that they're having a cardiac arrest. A lot of times that's what people might say, that I think I'm having a heart attack. They may feel that they have a pounding heart, or they have a rapid heart rate. Likewise, they may have sweating, trembling, shaking. They may have shortness of breath, so it's almost like they might feel that they're choking, or they can't breathe, or they have some sort of constriction in their throat. Likewise, with their breathing, sometimes they might be feeling that they're having chest pain or some discomfort, which may also sort of show up as abdominal distress, nausea. Likewise, while a person is experiencing a panic attack, they might sometimes say that they feel faint, or they have dizziness, they might feel lightheaded. Likewise, there might be other things such as a sudden feeling of being very cold or being hot. So hot or cold flashes are fairly common. Likewise, any numbness or tingling in certain parts of the body. Sometimes people will say that they're feeling pins and needles in their arms or their feet. Likewise, derealization is where a person might have a feeling as if things aren't real. People might say it's like being in a movie or a cartoon, or it's almost like their body isn't real, or they're detached from their own selves. Or they might have things like fear of dying, that the world is ending, something really horrible is happening. They might have a fear that they're going crazy, they're losing control. A lot of times people will say that I'm losing my mind, something horrible is going to happen, the world is going to end. So a lot of times these are very common panic symptoms, and like I said, that people might lots of times associate these with other things such as a medical problem, which is something we obviously want to rule out if we were, as a first aider assisting someone who is experiencing panic symptoms or a panic attack, we want to be very cautious that that's not something that's medically caused. However, these symptoms might appear quite similar. A lot of times, for example, with the last symptom I've mentioned, that fear of losing control, or that fear that I'm going crazy. A lot of times people might say that am I psychotic? Am I sort of is this going to be permanent? Am I going to be stuck in this place? This can't be. So a lot of times people are associating such words or such feelings with while they're experiencing a panic attack. So if a person is having a panic attack, what sort of assistance can we give as a first aider? So what can we do as a mental health first aider if we are helping someone who's experiencing a panic attack? So the first thing that we do want to establish is keep that fresh in your mind, what we've talked about in the previous slide regarding some of the symptoms of a panic attack and how they might appear very similar to sometimes a cardiac arrest. So we want to first establish with the person who's having a panic attack, we can check with them if they know what's happening and whether they've had a panic attack before. We can ask them if their symptoms are related to a medical problem. Let's be mindful that there's a possibility they might not be able to use words, so we may just say that, well, look, if this is a panic attack, just show me a thumbs up or just nod, just so that we can know if that's something that's more of an emotional health crisis versus if that is a medically relevant crisis. Our intervention obviously will be different. Like I said, that now that the symptoms of a panic attack can appear very similar to a heart attack or another medical condition, such as even asthma, a person might be quite frightened by what they're experiencing. They may want to seek medical attention. A lot of times they may see that they may say that call an ambulance. So obviously we want to call the emergency services if you're concerned that there may be a medical reason for the person's symptoms, or if they lose consciousness, or if they appear to have severe difficulty breathing, or if you notice that their skin coloration is changing. We obviously want to escalate that, and while you're on call with the emergency services, they might help you sort of problem solve through that if you need to do anything and what this might mean. However, let's say that if the person is somewhat engaging with you, we want to remain calm ourselves. We want to make sure that we ourselves are speaking slowly. So while we are regulated and while we are breathing, that in itself could be something that conveys to the other person that they are okay, because as we are not panicking. That's one of the things that once someone said to me, which is that, well, and then while you're in an aeroplane and there's turbulence, before you freak out, just sort of look at the staff, just look at the airline crew, because if they seem to be okay, well, they've been there before, and if they seem to be fine, then this is just something very normal. So while a person who's really in that terrified, shocked state that something completely uncontrollable is happening in their body and mind, they're feeling flooded, they're feeling they're going crazy, while they see you being reassuring, while they see you being regulated, that in itself is something that may help them be reassured. Likewise, what we want to do is we want to also verbally reassure the person. We can tell them that they are safe. You can tell them that, look, I understand that this is a panic attack. It might be frightening. I can see you're terrified, but panic attacks are rarely life-threatening. This will pass. It may feel like that these symptoms might stay on, but they never stay on. Panic attacks just end in a few minutes. If the person feels like they're going crazy, you can reassure them that they're not, and you're there. You'll help them. If there's a need to call the emergency services, you can check with the person if they need you to call someone. You can check with them if there's something that they do. You can check with them if there's a buffer that might help them. Likewise, it's very important for you to communicate a sense of safety. Also, just be careful that if this is physically, if a person is in a place where there might be potential hazard, you want to encourage them to move to a safe place. So if this is along a curb, or if this is at a place where you may believe that they might endanger themselves or other people, we want to ideally also make sure that this is private, so that the person is not overly concerned about how they're being viewed by other people around them. You can use their name, and sort of just that in itself could be very reassuring for them while you're speaking slowly, using a gentle tone, while you're being attuned yourself, while you're gently just calling their name. That might be quite reassuring. Likewise, please do give them some time. Generally speaking, we'll talk about some calming techniques soon, but usually once a person has started breathing and slowing down their breathing, it could be a couple of minutes, it could be 4 or 5 minutes, still they might sort of come back to a more grounded state where they're no longer sort of feeling those escalated, elevated heartbeat, or some of the other symptoms that we associate with a panic attack. So yeah, I mean, the idea is that you yourself, as a first aider, it's like when a younger person, while we're offering them physical first aid, and if they have a wound, we've been in that place before. We have a fair sense, which is it hurts a lot, and we are trying to be calm around that. We understand that here's a situation which in all likelihood doesn't need for them to be taken to a hospital. This is something that can be helped right there. You just need to apply pressure on that wound, or we need to clean it, or we need to apply a bandage, or any of those things. But while we are calm, it might sort of be a couple of those minutes while we're applying that first aid, while we're offering our own body and our own mind and our own sense of being present, stable, emotionally well grounded while we are in that state. That will also be something that the other person will resonate with. So those are some of those guidelines that you can keep in your mind. All right, so let's talk about some calming techniques, which are useful equally in your daily life, but especially when it might come to panic symptoms, someone who's experiencing anxiety, someone who's disclosed difficult information to you, someone who's presently in distress, someone who's feeling very intensely. These sort of calming techniques might come quite handy. Plus, you will also receive further resources from ADAPTS, which includes some training scripts that you can sort of go through and figure out your own version of that. You can sort of summarize it or take out elements that make more sense to you. So those are going to be things that you can consult. But let's have a chat about what could be some more immediate things that could be useful. So breathing techniques. There's lots of ways that with panic symptoms we can utilize breathing techniques. One thing that I've learned from a lot of my clients who reported that this technique can work, and this is sort of that very emergency sort of thing that could work. It's something very simple, which is just coughing. So while a person is experiencing panic attacks, what is happening is that the problem isn't in their breathing in. If anything, they're hyperventilating, and they're taking those short, shallow, quick breaths. And while they're breathing in very quickly in those shallow bursts, the problem is that they aren't exhaling enough. And while they don't exhale, there's a buildup of that carbon dioxide and that carbon monoxide. And while they don't exhale, the body is tricking them that they are lacking oxygen, so they take the next breath thinking that they sort of are lacking that air, and while they keep on breathing in, they're forgetting to breathe out. So a quick way of expunging a lot of that bad breath that's gathered up, which is dysregulating their breathing, is to ask them to cough. Not sort of a throat sort of a cough, but more a diaphragmatic sort of a cough. So while a person quickly exhales that bad breath, we are encouraging them to take the next in breath, and just the idea is to slow down the breathing. So while a panic attack is caused by, and there's research around that a lot of times panic attacks might, up to 30 minutes prior to an onset of a panic attack, a person might be breathing in that very shallow, quick manner. So one way at least of looking at a panic attack is just bad breathing. And to fix that, we are trying to help a person breathe in that way where we want to deepen the breathing. So instead of that very quick, shallow breathing, we're trying to deepen that breathing. There are a few ways of doing that. Like I said, the quick way to do that is to just cough. Another way can be what's called the box breathing. The box breathing is where you are sort of doing your breathing in a certain count. Now you can start with a count of 2, or you can do that on the count of 3 or 4. So it's inhaling on that count, such as counting on the on 2. So while I'm breathing in, I'm counting 1 and 2. Then I'm holding that breath for that count, 1, 2. Then I'm slowly exhaling on that same count, 1, 2, and then I'm waiting for the next breath for that similar amount of time, 1, 2. So this box breathing can be done on the count of 4. So inhaling on the count of 4, holding the breath on the count of 4, slowly exhaling on the count of 4, and then waiting for the next breath on the count of 4. That's box breathing. Or square breathing. Another way to do that is alternative nostril breathing. So basically, if you use your thumb and your index finger, you're covering one nostril and you're breathing in through the other one. And when you've already breathed through that, what you're doing is you're using your index finger to cover the other nostril. And now you're exhaling from the nostril that was covered by your thumb. And once you've exhaled from that, you're inhaling from that same nostril, and then you're covering the nostril with your thumb, and then you are exhaling from the other one. So that's alternative nostril breathing. You can do a simple breathing where you're just counting your breaths, such as you can count 1 when you're inhaling, 2 when you exhale, 3 when you inhale, and 4 when you exhale, and so on. The idea is just to focus on something else. Whereas when there is that onset of those panic symptoms, or we're anxious, there might be a flooding of thoughts or difficult sensations. What we're trying to do is we're trying to very slowly and gently move our mind and our body from those very chaotic, difficult storms towards something simpler, such as just focusing on the breathing or the counting. And look, sometimes that's hard, so we don't want to push a person. If we say that, well, do you want to breathe, and they say I just can't, I can't breathe. We want to also acknowledge that in those panicked moments, sometimes that's very hard. So a lot of times what we might do is we might just wait for a couple of moments. We may stay with the person. We may ask them if they're open to touch. We can check with them if they are open to that touch. We can just sort of maybe put our hand on their shoulder if that's appropriate to their gender, if they are consenting to that, or if they are open to their hand being held. So we are sort of, with breathing techniques, we can see if there's something else that might be comforting for a person. What we're also trying to do here is we're trying to lengthen the exhaling, because like I said, even with the coughing, the idea is that we're trying to very quickly exhale that bad breath. The idea around these breathing techniques is simple, that when we're anxious, when we're stressed, we breathe too much, we hyperventilate, and what we are trying to do instead is to exhale more, and we want to do that slowly. One way to do that may also be sort of breathing in through a straw or through your pouted lips, as if you were whistling. So while a person has already breathed in, we can ask them to just exhale with their pouted lips. What that might do is that slows down the same exhaling that we might do in just a moment. We're trying to spread that out over a few moments. So those are some breathing techniques, and you'll get more information in these. Then there are also techniques that can be used to reduce stimuli. So while people are experiencing anxiety or panic symptoms, lots of times they're experiencing what's called a sensory overload. So our five senses, our sense of hearing, touch, smell, sight, taste, they may be taking in too much information the brain cannot process, which makes the brain go into what's called the fight, flight, freeze response, which feels like a crisis. It can make a person feel very panicky and unsafe, and they might think there is that doom and gloom thinking that something bad is just about to happen, whereas what's happening in that moment is those are typical signs. It's a very evolved evolutionary response to threat. But the difficulty is that that can be set off by anything in the modern world. 10,000 years ago, that might have been a snake in the bush, or that might have been a bear, or that might have been a dangerous animal that might have set off that response. So it's a very highly evolved response that when we experience something threatening, there is these usual sort of signs and symptoms of that elevated heart breathing, and that sort of our pupils dilate, and our muscles sort of are ready for that response. Now, if that's set off by your boss sort of looking at you in a certain way, or by difficult life circumstances, or I feel rejected, that similar response can be ticked off. And while that is, we are experiencing those panicky symptoms. So one of the things we can try doing is reducing stimuli. So things like if we are in a very noisy place, we can try to reduce that noise by trying to be in a more silent place, or using voice cancelling headphones. Likewise, if we are experiencing that sensory overload through the movement or overcrowding, or too many things meeting our eyes. That's why green spaces, nature is so comforting to our nervous system. That could reduce the amount of stimuli that our brain is processing. Likewise, you can take a break from things that might be intense emotional encounters. You can make your environment comfortable, such as if there are very bright lights that are very sharp to your senses, you can try to dim them. Or if you feel that there are very strong smells, or if there's other things which are causing that sensory overload, we can try to minimize them. That could be comforting to the nervous system. Mindfulness is obviously that's a whole topic. We can talk about that for the next couple of days. We'll still have more strategies and techniques with that. So you will receive some scripts around mindfulness that can be used. There's a wealth of knowledge around mindfulness, and how that's useful towards anxiety and depression, and how, especially when someone is experiencing those panic symptoms, we can use mindfulness to sort of just from that very escalated place bring a person to that grounded space. It's a cultivated thing. We want to all invest into the skill set. It's a good investment into keeping your nervous system under check. There are things like body scans, where we are noticing one part of our body at a time, such as just focusing on one sense, such as what a person is seeing. Is there one or two smells that they can identify? Is there a certain taste in their mouth? Can they identify what they're touching against right now? Can they feel their back against their chair where they are lying? Can they feel their legs? Can they feel their feet in the shoes or otherwise? So we're sort of in the body scan. The idea is that we're slowing a person down, and we're trying to bring them out of their head into their body. That could be something that's intensely calming, especially when someone is facing those mental storms. There's too much happening in their mind. There's too many difficult thoughts, or there's too many intense feelings. We're trying to bring them from their mind into their bodies. So yeah, body scans. One of my favorite techniques of body scans is Dr. Daniel Siegel's Wheel of Awareness. So if you know his work, he's an interpersonal neurobiologist at UCLA. He has some wonderful works. If you want to review his book Mindsight, it's such a wonderful work on understanding our brain and its biology and how we can use that towards keeping our mental health in check. However, one of the exercises, and you should be able to YouTube that he narrates that's called the Wheel of Awareness. That's taking you through a body scan where you're scanning your five senses, and then you're scanning the interoception, which is what's happening in your internal organs, and then scanning your thoughts, any internal feelings, and then your sense of connection to your environment. I personally find that extremely relaxing, and that's one of my favorite mindfulness exercises. I can snap myself into sleeping in a couple of minutes while I'm doing this exercise. Do try it out. So yeah, mindfulness. There are other forms of mindfulness exercises, such as those cultivating observation. So just noticing what's there, and continuing to cultivate that sense of focus on what's out there. And every time thoughts or feelings hijack that observation, we just bring back to it. So even the simple thing, such as you can take an everyday object, I mean, whatever is lying around on your table, or just take a raisin or complex sort of things like a seashell or a rock or sort of something like that, just holding on to it and just cultivating that observation that you'd be surprised well how many details are there. If you just look at your floor, you'd be surprised how many details are there. And you might have lived or been in this office where you are for many years or decades, but you look at an aspect of the tiles of the floor or the walls, and you might just be surprised that, oh wow, I've never noticed that. So things like those. Likewise, they're practices that cultivate self-acceptance. There's some wonderful scripts out there. You can either sort of narrate these for yourself, or you can record these for another person, or you can read them out to a colleague or a partner or a friend, and just ask them to close their eyes and just to breathe, reminding them that they're safe. And you can slowly, gently read out those scripts for them to just imagine what it's like for them to receive what you're saying. All right, so then we also have calming techniques which are based on working with muscle groups. So progressive muscle relaxation is one such technique. We'll try to include a script on that. But the idea with progressive muscle relaxation also is we're tensing and releasing muscles. So if you want to do that, just a simple sort of body part such as your hands, you're just tensing, such as making a fist and holding that tension for a couple of moments, and then just releasing that, and just feel the blood flow back into your fists. Or just imagine sort of tensing your shoulders, so you're extending them upwards if that's comfortable for you. If you have any health conditions wherever that's difficult, maybe try to just do it as much as that's possible for you. So just tensing your shoulders, extending them upwards towards your neck and head, and just holding that tension, then dropping them. And while you drop them, just experience that relaxation that comes in. We'll include a script on this, basically where just like a body scan goes through each and every part of the body and different senses, the progressive muscle relaxation is also sort of taking one muscle group at a time. So we may start head down or feet up, the feet, the calves, the thighs, your back, your stomach, your chest, your shoulders, your face, your head, ears, hands, arms. So yeah, progressive muscle relaxation is a great calming technique. And yeah, one more that you can consider are just verbal affirmations. When we're anxious, when we're distressed, when we're stressed, we can say to ourselves gently, calmly, I'm safe, I'm okay, I have things that I need in this moment. We can say that to ourselves. We can say that to another person, especially someone who's experiencing panic symptoms. Just saying that they're safe with you, just reminding them that they're okay. You're there. You'll stay with them till these symptoms pass. These sort of things can be very calming. Yeah, so those are some calming techniques. That's a good skill set to have for us to utilize, not only towards as a first aider towards people who are trying to help, but for you to continue to invest into your own mental health and keep your own nervous system in check. All right, at this point, let's review some of the skills that you've already learned in bits and pieces when we've talked about depression, when we've talked about anxiety, self-harm. Let's put all of that together, that as a first aider, what are some of those essential skills in assessment and intervention when you're working with people. So one thing obviously that we're very mindful of is that when we're attending to someone, where we're trying to entirely be there physically and psychologically, imagine how difficult it might be that while we're being reassuring to another person, if we are on our phone or we're also texting on the side, it might not make a person feel that we're entirely attentive and present. So while we're attending to a person, we want to psychologically, physically, verbally, we want to entirely sort of attend to them. We want to have an attitude of non-judgment. That's easier said than done, but one way that we can do that is just sort of getting out of our own selves and recognizing that how another person is feeling, that's their subjective experience, and they're entitled to that experience. They're a human being very different from ours, from our own self, and just having that space where we can let another person be who they are, like we say in our field, which is accepting a person is very different from agreeing with them. So you don't have to agree with another person, but just sort of attending to a person non-judgmentally, accepting where they are, accepting, especially when it comes to things like self-harm. We might have a part of us that is looking at that person very critically and judgmentally, and we just keep that under check, that the person outside of us is distressed, they're having a really tough time, they're doing the best that they can. They're very different from us. We don't have to entirely understand or agree with their actions or agree with how they're thinking, but we can have a lot of acceptance and gentleness towards another person. Likewise, as a first aider, we also want to be very cautious that we are practicing confidentiality and our professional boundaries. What a person has disclosed with us in a vulnerable moment, we can have a chat with them that, look, yesterday you shared that with me, and I want to just reassure you that I will be keeping that information to myself. An exception obviously might be if someone might be at a risk for harming themselves or another person, or if they might have suicidal ideation or other difficult traits where it might be important to notify a person. Likewise, professional boundaries were for us to know where our skill set is sort of limited as a first aider, and what you should and shouldn't do. Like I said at the start of the training, that a physical first aider is not a replacement for the paramedic or professional doctor or someone working in the hospital who's going to engage with an emergency. Similarly, we want to be very mindful of this, that as a mental health first aider, what are our professional boundaries? What is the scope of our helping? Till what extent should we be helping, and at what point should we be referring on? Another essential skill is empathic listening. It's sort of trying to step out of our own selves and being there for another person. While we talked about depression, we talked about that skill that we're trying to really be present for the other person. We are trying to put ourselves in their shoes, that if this is what I was experiencing, and if this is exactly where I was, that ought to feel really terrible. Or if this is how I felt about myself, that ought to be a really difficult place to be in. Like I said, we don't have to agree with the person, but empathy demands that we're trying to put ourselves in another person's shoes. We're trying to walk a mile in their shoes, and we're saying, oh, if I were in their shoes, if I were who they are, if I were facing a situation like they do, albeit a very subjective situation, this is who they are, this is what they're experiencing, this must be hard for them, and we're trying to deeply empathize with that. And one way to do that is to listen in that manner, that we're not inserting ourselves in that conversation. Instead, we're trying to listen in through those rabbit ears, those really big rabbit ears, and we're trying to listen to the person. We can very genuinely be interested. Sometimes we listen to answer, but that very genuine interest in another person. Look, as I practice as a counselor, the longer I practice, I continue to feel that that's such an essential skill, that that in itself can sometimes just be enough for a person to feel that you deeply care. By your showing interest in them without trying to move the conversation anywhere else, keeping it where it is, showing interest, listening empathically, not being judgmental, being fully present and there for that conversation. And that can be really reassuring and healing for a person. So for us to have qualities such as resilience, being there, having that patience, having that humility, that if someone is sharing information with us, then really being humbled by that they're trusting us with that information, and us being patient with that, not demanding that a person be anywhere else where they are. There's that very interesting theory of paradoxical change, that change happens where we stop trying to take a person where they're not and keep them where they are. The more we can keep the person where they are, the more they get sort of that opportunity to metabolize their difficult experiences, and the more they can move past them. So we're trying to sort of, instead of quickly whizzing past difficult experiences, we are actually helping a person stay with where they are. And one way we can do that is by us being patient ourselves. And we will be taking this up, suicide risk assessment, in the next slide. That's an important element. At what points do we know that there are some safety issues? What do we do with that? Who do we notify? What do we what actions can we take? That's going to be something we're going to be taking up next. So this is a topic that obviously is very concerning for lots of people. It does make a lot of people feel the bit of that self-doubt that, hey, well, I don't know how I can help someone, or I'm being placed in that very difficult situation. Someone has disclosed about their suicidality. That's too much responsibility. I don't know what to do. So as a mental health first aider, if someone may be disclosing something about suicide, let's first talk about what some of those signs may be that someone is suicidal. So the first thing is looking for that ideation. So what ideation means is that, has a person disclosed something to us verbally, or is there another sign or a symptom that a person wants to take their life? Are they reporting something where there's a desire to kill themselves? Have they said something around wanting to procure a weapon or pills, or have they voiced their intention to harm themselves in a way where they want to, where they don't want to live. So that's ideation. A lot of times another sign that a person may be suicidal might be that their substance use has suddenly escalated. So with there's an excessive use of alcohol or other substances which might be quite uncharacteristic. A person might be experiencing a sense of purposelessness where they may be questioning not only the purposefulness of life generally, but they may see no reason for them living, saying things which to that effect that what's the point, or why do people live, or everything is meaningless. There might be anger, rage, especially if they feel that they've been wronged by someone, and there might be a lot of the expression of that anger in their behaviors. Likewise, there might be a feeling of being trapped, such as feeling that there's no way out of their present situation, and the only way out might be if they died or if they took their own life, or they might believe that there is no other way except their life ending, that this present predicament or how they're experiencing distress, that distress may only be over on if they died. There's a pervasive sense of hopelessness where a person may not only about the present, but they might also feel that towards other people, themselves, the future, where there's no chance of things being different. It might be common where someone is experiencing, let's say, that sense of suicidality, and you might be talking to them, and they might say, well, look, I've been unemployed for so many months, and if you approach that, well, hey, but do you want any help in getting re-employed? And say, what's the point? I'm never going to get a job. And it's almost like there's that negativity that things will remain exactly how they are and never sort of improve from that point onwards. Person may a lot of times withdraw, such as from their significant others, friends, family. They might have already started withdrawing, which might be a sign if they've been missing out work, or they don't respond to their texts or phone, or no neighbors have seen them come out of their house. These might generally be difficult signs that a person is suicidal. They might be experiencing anxiety, such as showing up in a sense of being agitated, difficulties in sleeping. They might not be able to relax. They might be fidgety. They may have a lot of difficulty sort of feeling that they're in charge. They have some sort of knowing that how to calm themselves. So a client might report sleeping all the time, or they might feel that things are too overwhelming. Small tasks such as going to the shops, or just sort of making a call might be too anxiety provoking for them. There might be a sense of recklessness. So when it might come with risky activities, it could be about without thinking about potential consequences, with sex, with money, with substances, with driving, with what they say to people. There might be a sense of that who cares sort of an attitude, that I can do whatever I want. Likewise, there might be sudden mood changes and very dramatic shifts in their state of mind. So you can remember this with this acronym: IS, path, WARM: ideation, substances, purposelessness, anger, trapped, hopelessness, withdrawing, anxiety, recklessness, and mood changes. The first time I learned this was in 2009 or 10 perhaps, and that's one way that this has stayed with me. That's a good way of just remembering. And look, this is obviously something for a clinician to establish, that at what point is something that needs to be escalated, and what are the treatment sort of interventions that are needed. But for you as a first aider, what's very important is just being able to identify that if even a few of these things are present, then the person may be suicidal. Whereas for a clinician, what they're establishing is the severity of that, the intensity of that, safety, establishing a safety plan, working with the depression. But for you as a first aider, we are starting off with just sort of an understanding that that what might be some signs that we want to be mindful of that might indicate that a person is suicidal. All right, so if someone has been displaying some of the symptoms that we talked about, what do we do? This is a topic that brings in a lot of terror and fear for even helpers and first aiders, because obviously one idea that people have is that if we approach suicide or that topic with the person, that might in some ways, what if that makes it worse for them? So that's a huge sort of a misconception that we might have, that if we speak to someone about suicide, talking to them about this might put this idea in their head. This is absolutely not true. Or asking a person if they're suicidal, this does not increase their risk. This does not put that thought in their head. Instead, if anything, it seems like most people who are experiencing suicidal thoughts, that's a very isolated and isolating place for them. And if someone is willing to speak to them, more often than not, that can down escalate those thoughts. This shows that somebody really cares, that they're approaching this. So when it comes to suicide, we want to approach that directly by asking a person that, are you having thoughts of suicide, or are you having thoughts of killing yourself? And like I said, don't be concerned that this might push them over the edge, or this might escalate their suicidal thoughts. If anything, it's something that might even help subside the intensity of these thoughts. So we want to obviously be very patient. We want to be very accepting. We want to be empathic. What we've talked about, active listening, all of these qualities of how we orient ourselves to a person. We want to use the same ideas that we've talked about during your skills as a first aider towards depression and anxiety. Similarly, even in helping someone who's suicidal, we want to use the same qualities. So a lot of times when someone may be feeling suicidal thoughts, they might be very intense, which obviously might be very panicky or shocking for even us. While you hear, especially a friend or a family member, say that they have lost their will to live, or they don't wish to be alive anymore, it can also sort of bring in a certain surge of that feeling where we want to immediately let them know that that's a wrong way of thinking, or they ought not to do. So we want to be very careful that we don't want to guilt a person, saying something like, "Oh, how can you think about this? You're a father." Or we don't want to minimize a person's experience. Let's say if someone has disclosed that they don't want to live because they've lost a huge sum of money, saying something like, "Oh, that's not a big deal," or "You'll earn that again." Even if that might be true, that might not be the right time or place to say that, because that might dismiss or make a person feel that then you're minimizing what they're feeling in this particular moment. So instead, sort of being empathic, that an appropriate response might be saying something like, "Oh, that sounds terrible. That you feel this way. That you've lost a huge sum of money, and right now that's making you feel that sense of shame, that you that's bringing on these feelings of suicide." Likewise, we don't want to personalize it by sort of making it about ourselves, that how dare you do that, I'm your best friend, or we take such good care of you, or you're my child, or what do you not have, we give you everything as a child, so why would you sort of do that? Or sort of that reaction we might have, that, "Oh, well, then fine, go do it." We don't want to dare a person. Look, when it comes to suicide, we want to take that seriously each and every time. That's not something, we all have the duty of care. Obviously, as mental health professionals or in other professions, there might obviously be even issues around liability. However, we have the duty of care, that we don't want to be reckless or say something unreasonable, reckless, such as daring a person, or diagnosing them or labeling them that, "Oh, this is what irresponsible people say," or, "Oh, you kids these days, you just feel suicidal at the drop of a hat," or something. We don't want to say them. Those are quite judgmental thoughts. They're obviously not helpful for someone who's experiencing suicidal thoughts. So things like saying, oh, you're just attention seeking, or this might be a cry for help, or you just probably want something from us. Those are quite useless approaches. We don't want to approach a person with those. So, what are some of the things that we want to sort of be very mindful of? It's obviously a safety issue, so we don't want to leave a person on their own. If a person has disclosed that there is a suicide risk present, you need to take those actions to keep a person safe, not to leave them on their own, or to check with them, which is who is another safe person in their life who you can call, and waiting for that person, that friend, that family member to arrive before you leave them. If you suspect that there is an immediate risk of a person acting on suicidal thoughts, we want to act. We'll talk about that shortly, that at what point do we escalate and what can we be doing. Likewise, this is also a very important question, who to inform. That would be related to the immediacy and the level of the crisis. And then that's dependent on where the person is. Do they have a plan for their suicide? Have they already organized some of those things that they need to carry out their plan? Have they set an intent? Do they know when they're doing that? We'll talk about that in the next slide. But those are determinants that may inform us that should we be getting in touch with someone presently, or is this something that we are trusting a person for them to take to their therapist or to another service. Also, never agree to keep this as a secret. A lot of times when people disclose something around their suicide, there might be an immediate sense of shame around what they have said. We never make that promise, especially when it comes to a minor. If you work in an educational setting, if a minor has communicated this information, that there are risk issues, obviously you are a mandated reporter. It depends in your state what your local legislation is, but generally speaking, remember that if someone says, well, can you please never say this to anyone, we can say something reassuring them. Look, I'm just concerned about your safety. Let's focus on that in this moment. I'm just worried about your safety. Let's talk about that. But I cannot promise that I won't tell someone. I want to make sure that you're safe. So let's focus on that presently. So let's run through this chart, which may help us assess the immediacy of the crisis and what our actions should be. So one of the things we want to inquire is if the person has a plan. And like we said earlier, they're talking about safety or asking if they have a plan or asking them what the plan is. That does not encourage the person, or that does not put those thoughts in their head. If anything, that might even be reassuring and normalizing for a person that they can talk about this. And sometimes talking about the person reduces the intensity of the person's thoughts about acting on them. So we are directly asking a person if they have a plan for their suicide. So we can ask how they might be planning to take their own life, where that might be, such as if they're disclosing, that might be in their bedroom, or if they might be saying, I'll jump in front of a train. We might further inquire, have you thought about where you might go, and at what time? Is there a certain station? And again, these are not leading questions. You're just asking those questions about what their plan is. Have they thought about this? Likewise, we are equally also seeing that have they made a decision whether they will be acting on this. So one idea is that is there a plan in place? Another idea is that have they what that plan is, and another is that what have they decided if they'll be acting on this. Likewise, we can check with the person if they have attempted or planned suicide in the past, which can generally be taken as a factor that's correlated with with more difficult outcomes. There's a higher likelihood if someone has attempted to take their own life in the past, there's a higher likelihood of them doing that again, or that being fatal this time. So we want to inquire about that. If a person is intoxicated, this can increase the risk of they're acting on some of their unsafe thoughts. So if someone is presently on any if they've overdosed on prescription medication, or if they have if they've drank, or if they're under the influence of some other substances, that can elevate the risk of their taking their life, because if they have that sudden thought, which they might have disregarded many times. Let's say that in the example I gave earlier, if a person has thought about jumping in front of a train, they might have thought about that many times, but that one time when they are intoxicated, their level of risk might increase, and they might act on that impulse. So we want to make sure that if someone is intoxicated, likewise, we want to know if they have the means of any things that are required to end their life. If they have said that they might shoot themselves, we can ask them if they have access to a gun. If they've said that they want to hang themselves, we want to ask them if they have access to a rope. So look, here's the thing. When the person is talking about their suicidality, it's a difficult conversation to have. However, rest assured, you're asking them questions about their plan, or if they require the means, what they intend to do, where, how, if they have an intent to act, if they have a present intent to act on them. That's not going to elevate the risk. There's a very good likelihood that a person talking about this might even be comforting. If a person is obviously saying that they not only have a plan, but they also sort of have access to the means, they've thought about what they'll be doing, and they've taken the decision. Someone is saying that they're going to do it tonight. You obviously want to stay with that person. You want to immediately notify 000. You want to act. You want to immediately act, and you want to escalate that. That's a crisis. That's urgent. That's immediate. You don't want to wait on it. But sometimes if a person might just have thoughts, and then they're saying that, well, I'm just having ideation, I've just thought about that I'm feeling very depressed, I'm not happy with my life, my partner has just left me, or I've just lost a bunch of money while I was gambling, and I'm just thinking that I don't want to live. But while you ask them, have you thought about how you might end their life, and they might say, I don't have any plan, I just thought that if I'm not living, I won't have to face this difficult situation. So if a person has no plan, if they've not thought about what they're doing, if they've not thought about acting on it, they don't have access to the means, generally that might be taken to be a very low risk, but that doesn't mean that we're not doing anything. We want to make sure that we are acting on even that. So let's look at what some of the options can be for us if someone is suicidal. When and what do we do given different situations? All right, so following from the previous slide, we've talked about ideation, plan, do they have access to means, and do they have an intent? So if someone has those thoughts, they have a plan, they have access to those means, and they do have an intent, obviously that's a higher risk. The intervention that we need to make is an emergency intervention is required. You want to immediately notify 000. That would be the right course of action. You can request for an ambulance if the person appears to be violent, or if they are in a difficult mindset. You can always notify them that it might be useful if they're also sending in the police. If the person has thoughts, has a plan, they may have access to the means, but they don't have an intent. So let's say someone who's saying that, yes, I do want to, and I've thought about hanging myself, I have a rope, but I'm not going to be doing this anytime soon. I haven't thought when I might. So obviously that's quite a escalated risk. However, that urgent intervention where we might need to call the emergency staff presently might not be required. However, this obviously requires an intervention, such as we need to either go to the hospital, or we need to make sure that the person is going to their GP, or having an assessment made at a hospital psychiatrically, if they are undergoing treatment for depression, for their physician, for the psychiatrist to know that the person has thoughts about ending their life, and for the physician to decide what should be done. Likewise, if a person has thoughts, but they don't have any plan, they don't have any intent. So someone just saying that, yeah, I mean, I've been thinking about death a lot, but they don't know, or have no intent of doing something, that might be a low level of risk. However, that's obviously not to be ignored. We do want to make sure that that's something that's taken to the right mental health professional. Either the person needs to be talking to their GP, or GP might screen them for depression, and they might see if the right referral for them might be to a psychologist or psychiatrist. Yeah. However, if someone has no specific thoughts, plans, or an intent, there might be no risk there. Generally, someone who's just having a conversation around death, but that doesn't always mean that there's a risk involved. So yeah, those are those levels of that intervention. Maybe sit with the slide for a bit, just so that think of any places where a friend or a family member might have shared something, and just say that which of these levels of intervention might that risk fall under. All right, so what are some of those services that you can refer a person to as a mental health first aider? So while there's a crisis unfolding, you can check with the person if there's a family member or an emergency contact, or other friends, anyone that they may want you to contact. If there's a safety situation, you obviously want to call 000. You can notify them what the situation is. They generally might ask if you need the police or fire or an ambulance. If there is a safety issue involved, you can say that you need an ambulance. But while you're speaking to the staff, you can also let them know that it might be useful, especially if the person is being violent or aggressive. You can always notify them that it might be useful if police is also on site, just to assist. But if let's say the situation has resolved itself, there's no crisis in place, there's lots of good telephone counseling services that are available 24 hours a day, depending on what a person's situation is. Beyond Blue is a good number to call for general issues of well-being, health, depression, anxiety. If a person is experiencing a crisis, Lifeline and the suicide callback service is specialized for someone who's experiencing safety issues, self-harm, suicidality. They might be good. Men's Line is a line that's dedicated to men's issues. Grief Line is a line that's dedicated to grief. Kids Helpline is a great service to call for children for people between 5 to 25. 1-800-RESPECT works with individuals who might be currently experiencing domestic violence. So there's a host of lines, and if a person has access to employee assistance programs, EAP services, that telehealth or otherwise is also available. And usually, again, there's a very minimum wait time on these, especially the telephone services that are immediately available. If you as a first aider are feeling that you don't feel entirely comfortable in what you've been able to offer, you can check with the person. Look, would you be willing to speak with one of the lines? Let's call them up. I can stay with you, and while a professional counselor is able to speak to a person, you can see what some of the suggestions are being made there, what would be some of their recommendations, if they might say that it's safe for the person to go home. So we do want to establish that safety generally before a person leaves especially if someone has shared something about their crisis or someone is in crisis. We want to make sure that they have a plan in place, how they can remain safe. Um, so simple things like what would you like to do for the rest of the day, just to sort of relax. Do you want to go get a massage, or do you like music? Do you want to cook your favorite dish? Do you want to go eat out? Is there a friend you want to go? Is there another place where you can stay tonight if you don't want to be alone? Do you want to have friends over? Is there something that might be useful for you? Have a chat about that. Or generally speaking, if they want to on a piece of paper or on their phone, sort of saying that, well, look, do you want to list down some people you can call if you're feeling that those suicidal symptoms again, or if you're feeling those anxiety symptoms again? Do you want to put down a few numbers there who you can call, who your emergency numbers might be, or what some of those things you could do, such as just putting it down that I can try to breathe, or I can listen to some music, I can go for a walk, I can try to do the diaphragmatic or alternative nostril breathing. It's useful to sort of have a few things penned down. It's similar to how the airline staff would tell us when their aircraft is on the ground, they'd prepare you for an emergency then. So the idea is that we want to plan and prepare for an emergency while it's not happening, because while an emergency is happening, we will be in our fight or flight response. We'll probably not be able to entirely understand or think or be creative around what could be done. But when we're relaxed, when we're not panicked, when we're okay, that's actually a good idea at that point to plan it out, that if we were panicked, if we were unsafe, if we were in a difficult crisis situation, what could be some things we could do. They could put this on the refrigerator, on their wall, in their phone, and just to remember that thing, which is that if I'm in a crisis, all I need to do is just look up this piece of paper that has that advice from me from that time when I was not in a crisis. So let me just trust that. Let me just do those things. Yeah, so as a first aider, what are some of the things that you can suggest to a person who is seeking psychological support in a situation that is not a crisis situation that can wait for the next day or that can wait for a few days? Usually a good place to start would be a visit to the GP's office. A GP, they can request for a longer appointment so that the GP can run a person through what's called a mental health care plan, where they can do an assessment for anxiety, depression, and a GP might be able to determine that what would be the level of care or what would be the right professional that a person may be seeing. Let's say for a non-urgent, non-crisis situation, such as a person wanting to work on their grief or to work on something traumatizing, they could sort of work with a therapist or a psychotherapist or a trauma therapist, whereas for other sort of psychological disorders such as depression and anxiety, there could be a host of different professionals who could be suited. It could be an accredited mental health social worker, it could be a psychiatrist, a clinical psychologist, a general psychologist. So a good idea would be to have a chat with the GP. Head to Health is a great resource. They have lots of good information there. Likewise, Health Direct is a great resource, not only just to gain information, but if you want to have a chat with a registered nurse, you could always use that resource. If someone is facing a crisis, generally speaking, a hospital would be a good place to contact. So whatever is the local hospital, just call their line, let them know what the situation is. It's a good idea to call ahead of time, because let's say if they have a long wait there, you want to establish that what level of intervention is needed. Let's say if you speak with the staff and they might recognize that this is not a situation that they might not be able to get to it in a couple of hours, then that gives us an opportunity to think about it, that what can we do. Otherwise, this could be a very difficult situation that let's say you take someone to the hospital and they're in the waiting room for a couple of hours. At that point, just waiting to even be seen by someone. So calling ahead of time, calling at the hospital, or an idea for you could be to call one of the helplines, call Beyond Blue, let them know what the situation is. They could call a hospital on your behalf. off, or they could do that triage. They could help with that triaging, or 000 could help you with that situation if there's a crisis situation. Likewise, if a person already has a psychiatrist, or if there's a situation where a person might require inpatient hospitalization, or they might require some long-term care for their mental health symptoms, usually that might be a specialist referral that's going from the GP to a psychiatrist, who might then be able to determine what sort of care is required. Would that be done in a community setup, or would that be done in a hospital setup? All right, so we've spent quite a lot of time today talking about mental health first aid and its application to various conditions. So let's try to apply this on two specific cases now. Ali is a 26-year-old colleague you found in the restroom. She appears to be shivering and is in the fetal position on the floor. She's crying while gasping for air, and she's saying, "How could this be? There seems to be vomit on her sweater. There is no one else in the restroom." So I'll just give you a moment to read this and see what comes up for you. So now if you're on your own, you can try to think of these questions with yourself. If you are with other people, if you're with a group of people, you can all discuss this with each other. But what sort of themes do you see in this? Is there something that we've talked about today that you reckon that this could apply here? Could this be something around anxiety, or could this be something around panic? There's vomit on her sweater. Should we be concerned about her safety? Is she choking? She seems to be having difficulty breathing. So while she's saying, "How could this be?" Do we want to know more about this? So yeah, those are some of the things you can consider. It doesn't appear that there's some safety issues here, but we can always check if they're safe. And here's another case of Mark, who is a 40-year-old friend who's recently been diagnosed with cancer. You're seeing him for the first time since his diagnosis, and he discloses that he's lost his will to live and has been wondering about the meaning of life. I'll give you a moment just to read this and just sort of to bring it to your mind's eye what might be happening here. You can wonder what we talked about depression. Do some of those symptoms appear here? We're obviously not looking to diagnose. That might be quite appropriate for someone who has heard such terrifying news, for them to sort of feel that sense of purposelessness and questioning the meaning of life, feeling really bitterly, being angry. But we can wonder if there's any safety issues when they say that they're losing their will to live. We can directly ask questions such as, are they thinking of taking their own life? If they're saying that this is just a response to the bad news they've received, and then that might not be that there is necessarily a risk here. Mental health first aid in that case might just be all of those things that we've talked about, providing that reassurance to the person, being there for them, really just encouraging them to seek that professional help, for us to take the time to talk to them, to offer that emotional support, for us to be those safe people that they can continue to talk if that's useful for them. We can use all our good listening skills, asking open-ended questions, and also sort of importantly sort of asking them what's useful for them. How would they like to receive support from us? All right, so we are at the end now. You can now go to your quiz and use the wonderful downloadable resources. That's going to stay with you just to go over these again, or some of the things that we've talked about. Good luck with this. Thank you for being here and attending this training on mental health first aid. And today we've looked at various things of what you can do to assist someone who's developing a mental health problem or experiencing the worsening of an existing mental health problem, or if there's a present mental health crisis. What sort of things can you do as a first aider till professional help is received or till the crisis resolves? Thank you so much for watching, and I hope to catch you another time.